All right. Next, it's my pleasure to welcome Dr. Allison Dempsey, who's a licensed psychologist, director of the Connections Program for High-Risk Infants and Families, which delivers mental health services to infants and their families in our university NICU, as well as to families across the state in the associated outpatient program. She's a professor in the Department of Psychiatry here on this campus, and she is in a whirlwind tour of giving various talks this week. She just gave the neonatal noon conference to our neonatology group yesterday. So I'm so thankful for her carving out some additional time to share her knowledge with us. Okay, let me figure this out here. Okay, so our team is fully integrated into the University of Colorado Hospital NICU. We work really closely with our partners in developmental therapies, social work, nursing, physicians, and chaplains. And our unique lens is looking at co-regulation for the babies in the NICU. So we are not there to provide therapy to parents at bedside. If parents want therapy, we can refer them to outpatient services. But what we're really focused on is how we can engage the parents and the unique care that they can give to their babies to improve their babies' outcomes and medical course across the state. And we base this on this idea of co-regulation, the idea that parental emotional regulation, so how they display their positive and negative responses to NICU stress, co-develops with how the baby learns to self-regulate themselves, which we talk about at this age as physiological regulation to stress. This is the general model that we use. So we recognize that being in the NICU is a stress. It's a stress because you have a sick baby, because you're not at home, because you may have other responsibilities, many, many stressors for parents. And there are opportunities for how we respond to stress where we can intervene. So when anyone is faced with stress, they have different ways that they regulate those negative emotions that come up. They can approach or avoid a situation. They can try make attempts to try to change the situation. They can try to distract themselves from what they're experiencing. They can alter their thoughts about how they're thinking about it. And then they can also change how their overall body is responding and how they are emotionally and behaviorally responding to this. So in the NICU, here's some examples of that. So when we think of, and I should pause and say, emotional regulation can be adaptive and positive, and it can also be maladaptive. And everybody employs these strategies, both adaptive and maladaptive, throughout our lives. It doesn't mean that it's a psychopathology when we show negative or maladaptive reactions. But some things that we may see is, for example, in avoidance or approach, we may see a maladaptive reaction where parents start getting worried about visiting bedside or engaging into skin-to-skin care or participating in care tasks. They may withdraw from rounds or avoid speaking with providers because that causes so much stress that they found that avoidance is an adaptive way for them to try to bring that stress down. They may try to modify the situation. So sometimes relying on rigid or controlling behaviors, who can touch the baby, what nurses they will have, what they won't have, and so on. They can try to change their attention. So they may be on their phone when the teams are trying to talk to them. And that's not being disrespectful. It's a way for them to kind of tamp down, try to get that emotional regulation back into place. Or they may become ultra fixated. So if I just watch the monitors while I'm feeding my baby, I'll know if there's something wrong rather than looking at the baby for cues. In terms of how they interpret things cognitively, we can see misinterpretation of infant behaviors. Oh, my baby won't feed because he doesn't like me, but he likes my nurse. Or being just really critical of oneself. I'm a bad parent because my baby's still not feeding, or my baby wouldn't be struggling so much if I were a better parent. Or they may behaviorally have response modulation. They may cry, shut down, become angry, or even have panic attacks. And so these are all the things that can happen when we're not working with families to focus on this emotional regulation. But in all these examples, this also affects how the baby's care is going if the parent isn't able to hold or isn't able to work collaboratively with the team and so on. And so this is what our model is for how in the longer term we think that this affects overall bonding, infant self-regulation, and short and long-term outcomes. So we have this exposure to incredible stress. And with this, we can see some decreases in adaptive parent emotional regulation. Again, it's actually a healthy reaction to a really unexpected situation. And as part of that, we can see reduced parenting efficacy, so they don't feel like they have a role in parenting their child when they're in the NICU, and engagement with the baby, with the team, with family members, and so on. And then these can lead to disrupted medical or relationships with the medical team, decreased bonding with the baby, and less opportunities for the parent to teach the baby how to regulate themselves. Overall, we know this is associated with longer medical stays, less breast milk feeding. We can see delayed readiness for discharge, and in the longer term, things like executive functioning difficulties, anxiety and depression in the infants, and struggles for the families, parental mental health as well. And so our team really focuses on these two boxes when we work with families in our NICU. So we see all families automatically if the infant is born 32 weeks or below. So everyone that we see gets this intervention. And then if there are those who are older, who the team also asks us to see, some of those will get this intervention as well. So we developed our NICU Parent Readiness and Engagement Program, or we call it NPREP, as a way to disrupt this process, to really target those two boxes. And so this is based on cognitive behavioral and acceptance commitment therapy principles, coupled with infant developmental pathways and infant mental health theory. And so we used all that to create this 4-session intervention that we aim to deliver weekly. And so each session is made to stand alone. We recognize that we may not have 4 weeks to meet with these families. Babies can get transferred. Sometimes they have a demise. Sometimes they're doing better than expected and they go home sooner. And so each one of these is standalone, and we hope that we're helping parents develop emotional regulation and an infant self-regulation target through these therapeutic skills that we're teaching. So we focus on sensory needs. We focus on how to engage in mindful and value-based parenting, how to set routines and live a life that you would expect as a parent, even if you're in a prolonged NICU stay. And then finally, how to really focus on how do you look at your infant and read their cues and understand their readiness for different situations. We used a phased developmental approach to develop and refine this, and focused on looking at both how to implement it, and then how families respond to this. And I have Children's Hospital of Colorado Springs down there because although this was developed in our UCH NICU, we partnered with nursing and psychology down at CHCO Colorado Springs to also do an implementation of this to see if it would be something that would be feasible to do in their NICU as well. And throughout this process, in our first stage, we really focused on content, developing and refining the sessions. The next stage, we looked at acceptability. Do parents like this? Do they feel it's appropriate for this time in the development? Is it feasible to implement? And then finally, outcomes. And then the Colorado Springs was also about scalability. Can something like this be taken and applied to a new setting with obvious modifications for the needs of those families and the workflows in that unit?
You get in the back soon.
So in terms of feasibility and acceptability, these are some of our data. So for everything, we collected both quantitative data from parents, like surveys, or rate on a scale of 1 to 10, how much this session addressed this thing, for example. But we also did a lot of qualitative interviews as well with all the families who were willing to participate to get a sense of what they liked about the intervention, what they didn't, what worked, what didn't, and so on. And so when we talked with these families, overall, they described this as a supportive intervention, appropriate for the NICU, and that was responsive to their needs. In blue, I have some quotes that we pulled out. It was hard to choose some because there were so many good ones, but one parent said, it really makes the hard experience a lot better. So just overall experiential. Parents liked that the sessions were held weekly. We specifically asked about the timing and delivery of sessions. They felt if they were more often, that would be too much, but if we spaced them out, that wouldn't, they wouldn't be able to develop the skills as much as they wanted. We also asked and looked at when we should start this. We started with should we start this right away in the NICU? Should we start at 4 weeks once you're kind of settled? And what we heard overall was that about after the first week, but sometime maybe in that second week is the best to do this, because the first week is such a whirlwind. Parents are still trying to just get the lay of the land and figure out what just happened, how are they here? And so it's once they get settled that this can be really helpful, but they didn't want us to wait much longer because they felt it was a really critical window of opportunity to start developing these skills before maladaptive regulation skills can kind of set in as habit. They loved that it was hands-on and experiential. So every single one of those modules has an activity base to it, from making art with the child to reading certain stories or developing a routine with them. So everything, and they also get a little takeaway memory making experience from each of those sessions. And then they also just liked that it was relational. So parents said it gave me something to look forward to every week. It helped me get into a really good heart and headspace before going into the hospital. And those were, again, some of the skills that we taught them. And then some parents did say that 4 sessions wasn't enough. They wanted more sessions. They would have liked it to continue. And they also struggled if they transferred to another unit that they weren't able to continue this as well. We really looked at 4 main outcomes. And we looked at this from a qualitative perspective and a quantitative perspective. And the first one, of course, is emotional regulation, as I've been talking about. And we didn't ask parents specifically, did this help with emotional regulation? We said, how was this helpful? How was it not helpful? And then tried to draw the things from there. And emotional regulation came out quite clearly. One parent said it was taking my mind off some of the scariness and unpredictability and being able to kind of channel that into feeling like something that's beneficial for me as well as my family. And we also saw medium to large effect sizes in reducing or in improving emotional regulation. So parents talked about their ability to self-calm and cope with the negative emotions and the stress. Parents talked about self-efficacy, so it helped me feel more active in my son's life instead of just sitting there, because we know that sometimes parents don't know what to do in this situation. And we saw medium to large effect sizes in terms of just feeling like they could improve and engage as a parent with their baby. Some parents talked about bonding, and it seemed that it emerged later on too, based on our data, that we saw more effects for bonding. So they were smaller in the at like the 2 to 4 week period, but later on at about 40 days, we saw that we were had more bonding effects. So one parent said, I wish every parent could do something like this. Like they'd hear your voice. I can just hear I sing certain songs for her and her little brain recognizes that's mom. And that was just such a beautiful quote, because the parent was starting to recognize that they are a real partner in caring for their child and that they can actually form a very special relationship with them in the NICU. And then also parent sensitivity. So another parent said, I realized when I started to sing to him, he would actually calm down. And so she was able to link that behavior also to how the baby responded. And when we asked parents, how did this help you respond to your baby's cues? In our quantitative questions, we saw medium to large effect sizes as well. So our key takeaways are really that promoting emotional regulation can definitely improve these dyadic interactions and engagement. And it's really important when we're working in NICUs to identify how families receive this kind of structured co-regulation support within the existing resources and frameworks that you have. Nurses can do this, social workers can do this, developmental therapists can do this. It's just that explicit teaching and really giving the parent space to develop these skills. If possible, it's really important to make sessions standalone, because families will miss sessions, especially if they're transferred. That was the majority of the reasons that our families didn't get all 4 sessions, though 75%, or I think 80% got at least 3 of them. And then make sure you're designing for real workflows and families and thinking of what their preferences are, when they may transfer or discharge. We found that it was helpful that families can't always be there at bedside at, 7 to 6 or 7 when we're there. And so there were times when we would be at bedside and meet with the parents virtually on an iPad so that they can see the baby and they're going through this session together with us. And then also really think about the relational aspect of the delivery. Having a consistent person who's going to them and teaching them this was something that they really valued as well. I think that's all I had. Thank you.
Thank you so much, Allison. That's fantastic. Let's open up for questions for any of the 3 presenting groups. I'll get started. I have a question for the first two, from Colorado Springs as well as from St. Joe's. I heard a little bit around how we likely are doing more of family integrated care, more engagement work when the census is a bit more reasonable. And so when the acuity is high, when the census is high, staff bandwidth are limited, what happens? I would love to hear your experiences and potential opportunities to maybe adapt what we're doing for a busier, a sicker context.
It's interesting that you say that because when we have been super, super busy, our nurses are like, oh my God, thank heavens the family is here. I wouldn't be able to do it without them. So
actually having the families involved perhaps eases the burden on some of the nurses. What about our Springs team? Any thoughts?
Still, family round, and we still get out there because our NICU is very fortunate. We have 2 charge nurses that are out staffing at all times. It's not negotiable. We have a resource nurse when we're over 35 babies, and we have a second resource when we're over 46. So we're still expecting to get out there and make sure that we're building relationships and making sure that everybody's treated with kindness and respect. So.
Other questions?
I have a question for the Colorado Springs team. It sounds like neighborhoods have gone really well in your hospital, and so we did something recent at the Anschutz campus. In the presentation, I was wondering, how did you split up your neighborhoods? Did you do it based on patient population, or is there still a spread of different diagnoses?
Sure.
And you said that it took burn off of primary nursing. Did you eliminate primary nursing?
We did eliminate primary nursing, and it was a cultural shift, so it was kind of difficult. And a lot of the questions that came up prior to it, it was nurse-led. So it was through our clinical advancement project. We had a team of 4 nurses and myself that led this project to gather data. And some of the pushback was that there was concern that only the small babies would be admitted to certain neighborhoods, and maybe only certain babies would be in certain neighborhoods. But we don't do that. We admit any baby into any open bed, and we keep a pretty high census. So each neighborhood experiences all the different spend and acuity. There was some concern as to whether or not nurses would have to schedule in their neighborhood scheduling groups, and we don't do that either. So we have sister neighborhoods, so like A and B are together, and C and D. So you don't have enough C nurses, for instance, then a B nurse could cover this D. And so the families are getting to see the same faces all the time, even though they might not have the exact same nurse. And so that's the same thing with our primary rounding with our leaders. So like when Chelsea rides, everybody knows it's either Sheree or Kelsey, and we are able to have continuity in both day shift and night shift. And then for, what was the second question? Oh, burnout. So on our primary nursing, everybody loves babies. We're all here for the right reasons, but sometimes there are challenging social dynamics and things like that. And so nurses were asking for a break from their primaries, and that doesn't serve as a continuity of care. And that also makes the families feel like, well, why is Brandy here today, but she doesn't have my baby? So if you have a team of nurses in a neighborhood, we're able to kind of rotate the nurses around if need be and spread the love. Any other questions?
Right there, yeah.
Mary Kate online, I think this is for the St. Joe's team. Wanted to ask how you got buy-in from the nursing staff to start the family live care.
That would be Elena.
great question. If we just adopted it and moved forward with it, so there wasn't, and we did struggle at the beginning with not all nurses wanted to do it. Not all nurses had a passion to do it, and it just became a requirement. Same with the care conferences, like it's non-negotiable. Like if you're born less than 1,500 grams, less than 30 weeks, you will have care conference. So it wasn't. Yeah.
I have a primary nursing question as well. So if I do the math correctly, there's maybe 12-ish beds in each neighborhood. Okay, perfect. So 12 to 14 beds in each hallway, and then the nurses stay in that hallway, generally speaking. Did you see an increase in nurses requesting specific patients to charge nurses, or did nurses not have a lot of autonomy around requests for patients because the primary nursing was eliminated?
We don't really get requests per se for patients, because at some point, since it's only 12 to 14 beds, they're taking care of all the babies. They are still able to request, for sure, to have that certain experience, or if they had, an orientee or something like that. So our preceptors don't necessarily stay in their neighborhood because they will offer those experiences. But other than that, all of our, new to NICU and our experienced NICU nurses, everybody has to choose a neighborhood by 3 months. And then look at the FTEs and kind of let them know, because obviously you can't have all, so like in our neighborhood, it is high speed, so a lot of people love that. So, we can't have everybody in the neighborhood. But it's going really well, and as you can see by our slide, our staff is pretty well engaged, and our patient family experience scores reflect that it's going well. In 3 months.
Hi, also from Colorado Springs. I liked your nursing notes that you guys were talking about, and I was just curious. We don't have our kids at the bedside all that often, so how do you engage with families? Like, for example, the one that's like, "Mom, you did a great job," or "Great job with the model." Do you have a way to communicate with families that aren't at the bedside, or do you still use those notes kind of as like, "Here's what happened during the day"?
Great question. So a lot of our communication also comes through Epic. I know that some nurses reach out through just the Epic chats for parents and acknowledge them that way. These love notes are just a way to leave something for the parents. Like at some point they come in and just having that, like if I'm a night shift nurse and the mom doesn't come in until 11 o'clock in the afternoon, it was a way for the night shift nurse to be like, "Oh, I took this much of my bottle, hooray for me, and I'm doing a great job." But also like the ability to leave the mom a note from the day shift nurse, they can acknowledge what the parents are doing. So.
All right, fantastic. Oh,
And along those lines, when you're trying to get those levels, whatever, and the all about me posters, do you have those resources in Spanish as well? For example, for moms that speak Spanish or or other languages for that matter, how do you handle those other languages? Because I assume not all nurses are bilingual or multilingual.
That is something that we're always continually working on. We don't have, we have Spanish interpreters all the time in our unit, and so we're able to utilize those. As far as the love notes are concerned, having that bilingual, being able to communicate with somebody that is Spanish speaking or have a different language is a little more difficult, but we do try to elicit those other language lines and things like that of that nature to help those communication styles. So.
yeah, and I think we'll certainly do a deeper dive on that with our expert interpreter here.
Thank you. I just had one quick question for St. Joe's. Is that dot phrase for the family care conference? Is that accessible to anyone that's on Epic?
I think so. I'm not sure, Jen, do you know?
Usually dot prices are only for people in the specific.
So I wonder if we've created it. I wonder maybe we created it. I can get back and email to them.
Yes, that'd be great if you could share it. Yeah, the crazy thing with Epic is that you can upload these various dot phrases and tools into the Epic warehouse. And it sounds like this mysterious place, but it really is this cloud-like universe of all things Epic that crosses hospital systems. So if it's available in that warehouse, it can be downloaded and used in your system. Now, the other kind of barriers within certain systems, it's quite a process to say, I want to put in this dot phrase. That's a whole nother, but it is accessible. All right, so let's go into our integrate and reflect session. And much like the other sessions, the goal is to share the education you gained, knowledge you learned, and then importantly, what are we going to do with that? what opportunities are there to improve care, and what are some specific steps that you'll take tomorrow or next week in your NICUs.